right, so I'm going to start the record and hopefully you can share the screen. Just make sure. All right, perfect.
Yeah.
All right, we're going to get going. So thank you all for coming to another one of our trauma conferences. Tonight we have a true guest, Tom Grissom from Shock Trauma. He's here he really doesn't need much introduction to the trauma field, but he's here to talk about some of his favorite papers for the last year and the impact that they've had. Again, please share your names so you get CME credit. If we will be posting this up onto the Trauma Anesthesia Society YouTube channel, so that I will hopefully get that up this week. If you guys have other ideas for lectures, any questions, anything that comes up, please let me know. But with that, Tom, the floor is yours. So thank you very much for coming and joining us again.
Well, thank you very much, Justin, and for everyone else there. Hope you're having a wonderful day. I got out early, so it could not have been better for me. This talk has sort of evolved over several years. You know, I have a tendency to sort of peruse the literature and frequently try to get outside of, you know, the mainstream anesthesia topics and journals. And it's always interesting. Before I do this, I typically talk to our trauma surgeons and ask them what has changed in your field. You know, so it's not just the things that we do that we see in our own, you know, specialty, but things outside of our specialty that may have an impact on how we practice in the future. You know, I think this is just the consideration is, you know, as we see new information coming out, you know, how do we anticipate that this may change our practice or may influence some of the things we do, and specifically for us, you know, in managing the traumatically injured patient. You know, I could say that I have no disclosures. Like I always say, I've got 7 kids. So if anybody wants to give me money, I'm more than happy to take it. But right now, there's nothing in this particular presentation or otherwise for which I do have a conflict of interest. You know, from an objective standpoint, again, I think as we look at the literature as it comes out, it's important that we apply, you know, our critical reasoning skills to these new advances, this new information, and decide how and if it is going to affect, you know, how we manage the specific patient populations that we deal with. And also, I think to a large degree, you're going to find out that in the last year, there have been a number of publications, number of projects, specifically looking at the use of whole blood. Something that I know that, you know, the folks down there in St. Louis, WashU, obviously have access to. We have it here in Baltimore, and it's seeing increased usage over the last several years. And there's a number of other places where we've incorporated it, you know, into our practice. And I think, you know, if you look at what's happened in terms of the literature in the last year, we're starting to see some things that maybe suggest that places that haven't jumped on the bandwagon yet need to really start considering it seriously. You know, when we look at trauma around the country, you know, one of the things that, you know, has always been important to look at, I think, whenever I speak to different areas or different, you know, groups around the country, is what is your access in your area to the trauma center? You know, that graph there that you're looking at on your left-hand side is one that's been out for a number of years now, but it really hasn't changed a whole lot. If you look at those areas where there is red, you know, that is where we have the highest injury death rates in the country. If you look at those areas marked in sort of that light color blue there, those are areas where individuals living within that geographic region have at least, you know, a less than 60-minute time access to a trauma center. You know, if you see where the purple is at, that's where it happens to overlap, where there is a high access and also a high injury death rate. When you look at, you know, St. Louis, as you can see right there, you know, in the state of Missouri, you know, there are a fair number of trauma centers, but when you actually look over at the bigger map on the left-hand side, there's a lot of areas of red. You know, that reflects our rural areas where we have limited access to trauma centers. And as we've seen, we look at some of these special access centers around the country, they're having increasing difficulties staying open and providing care in those particular regions. So it's important to do that. And now I only bring this up to one large degree is to talk about, you know, the thing that I always have a problem with when I do these presentations is I'm at a major trauma center, just like the folks at WashU. And there is no problem getting patients to us. If you looked at that previous graph and looked at the state of Maryland, we're entirely blue. There is not a portion of the state of Maryland where you can't get somebody to a major trauma center in less than 60 minutes from time of injury. And that is to a large degree supported by the fact that we have pre-positioned helicopters that are part of our state, police sort of system. We call them the troopers, that are manned by law enforcement officers who are also paramedics. And they have the responsibility of moving patients with severe traumatic injuries from all around the state, not just to shock trauma, but to any of our other trauma centers, depending on the level of injury and the urgency of the situation there. And when you look at shock trauma, we're right there in the middle of all that, where Baltimore is located. And that is referred to here in Maryland as our primary adult referral center. We don't use the American College of Surgeons classifications. We use sort of our own internal review process, our internal classifications. But this basically put STC as not just a level 1, but sort of the primary adult referral center. And for those of y'all who ever come to visit Baltimore, I highly recommend pulling up this particular map. It's available on the Baltimore Sun webpage. We just call it the murder map. You can actually bring up all of the homicides in Baltimore and see where they occurred, over any time period, as well as mechanism, et cetera. And if you look at it here, that little star bouncing in, that's shock trauma, kind of right in the middle of all the action there. We are a specialized and sort of separate center. If you look at this picture on the right-hand side, you'll see what is actually the University of Maryland Medical Center. The R&M County Shock Trauma Center is located sort of on the end of the building with our helipads on top, but it is essentially independently functioning hospital. So we have access to resources and obviously support from our pre-hospital personnel that exceeds what many people have around the country, and we realize that. And we also have, again, a dedicated group of anesthesiologists who specifically work with our traumatically injured patient population. When our patients show up at our hospital, it's a little bit different. I'm not sure how it is in your institutions, but we get individuals who come in, and when they are seen by a trauma surgeon, the trauma team, as well as an anesthesiologist. This is not the emergency room. So there's not an emergency medicine program for which we're competing for airways, procedures, access, et cetera. It's really a tight functioning group of individuals, both anesthesiologists and surgeons, primarily managing these patients from their initial presentation into the operating room and into the perioperative environment. Now, in the next 40 minutes, what I'm going to try to do is go through what I thought, at least for me, were the most interesting papers to come out roughly within the last calendar year. I think, what's newish in trauma management, obviously, as I mentioned earlier, whole blood and some of the many studies that have come out, supporting its use. A little bit on adjuncts for massive hemorrhage. And I think for the most part, just as a reminder, what I'm going to try and do is make quick points here. Got a lot of papers I really want to talk about. And I'm sure what it will do is engender a lot of conversation towards the end. So I'm really going to try to finish on time, if not a little bit early, and go quickly through this so that we can have some discussion, because I learn as much talking to y'all as hopefully y'all get from just, getting a quick overview of the literature here. So, I kind of want to start out with how things have changed just in the big picture, to kind of focus in on the specific topics that we're going to bring up. This is how I was taught 30 years ago to resuscitate a patient with major hemorrhage, in shock, presenting whether it's blunt or penetrating. And that was actually to get the patient through a definitive surgical intervention. This didn't mean the damage control process we do now. I mean, we would actually resect bowel, do anastomoses, and try and do all the surgery and close the abdomen, something that we frequently don't do now under the guise of our damage control resuscitation and surgical approach. The other concept was we really wanted to aggressively restore intravascular volume, which frequently led to the liberal use of crystalloids, and pack cells, obviously, if needed, as part of the resuscitation. I don't know about you, but it's been many, many a years since I've had a patient in the OR as a major trauma resuscitation and administered more than just a few liters of crystalloid. But 30 years ago, we get patients coming out of the OR with 30 liters of crystalloid on board. And you can imagine what they looked like. Treating coagulopathy, we weren't dealing with, resuscitative ratios. We weren't dealing with the administration of, platelets empirically, et cetera. We treated coagulopathy as indicated by lab data typically, and we were still aiming for hematocrit of 30, which we all know is kind of impossible. I sort of refer this to as my, sort of caveman days. And the key point here is that liberal use of crystalloids, which we know, if anything, is probably one of the worst things we can now do for many of our patients who are presenting in hemorrhagic shock in the setting of trauma. And this, of course, led to what we dealt with for many years, fluid creep, right? Excessive use of crystalloids leads to hypothermia, you get hemodilution, worsening of your coagulopathy, acidosis. There may be damage to the endothelial glycocalyx, one of the more recent topics we've kind of gotten into with resuscitative medicine. Activation of our inflammatory cascade, and again, obviously all the edema and fluid that went with that. So when you look at that, we've had some evolution of our resuscitative approach in the last several years. We've gotten away from our too much crystalloid. I think even 30 years ago, we were starting to think, okay, we need to give less crystalloid and get more into our blood products, which at the time were really based on component therapy. Obviously then came along the concept, around early 2000s, of this sort of a ratio-based resuscitation based on some of the military experiences, suggesting that increased use of FFP, platelets, sort of to mimic the administration of whole blood in combination with packed cells, was probably a better way to approach our early and initial resuscitation with these patients. And now we've sort of, I guess, like to think of it in terms of evolution, kind of default right back to whole blood. And that's where all of our blood transfusion practices started with, was the administration of whole blood for patients who required a transfusion. Here in Maryland, we have actually now have the availability to have whole blood available on our trooper system, the helicopters that go out to our scenes and actually bring many of our patients to us. And even some of our ground-based units now are starting to have availability of whole blood at the point of injury. Now, this is amazing because if you really look at the data that was out there, and this is a systematic review done just about 2-3 years ago now. And at that time, while they identified 126 references with potential implications for the administration of whole blood, they only found one that actually suggested that there was benefit. And when they actually went down and tried to look for a quantitative synthesis based on a meta-analysis, there were no studies that they felt were adequate to be included in that sort of analysis. And as it suggested, even those studies that were included in sort of a qualitative assessment, there really was no clear benefit presence with the administration of whole blood. So looking at the first article here, again, this one has actually been out just a little bit over a year now. We're starting to see a number of institutions, a number of collaborative groups putting together their observational data, given the fact that we now have many places that are using whole blood as part of their resuscitation in both the pre-hospital and early hospital admission phase. And we're starting to see what may be the true impact of the use of cold whole blood for resuscitation of our patients. In this particular trial, which came out of Houston, one of the places where they had very early adaptation of both pre-hospital and early admission administration of whole blood products, they looked at their experience. So this is a single center in Houston, looking at 1,300 patients receiving some form of emergency release blood product. And you can see here, when they did their comparisons by their definitions, they had a pretty large percentage of folks who actually got whole blood as part of their resuscitation. And this included both administration in the pre-hospital and emergency departmental setting. There were a lot of things that came out of this study that I thought really kind of intrigued folks, primarily which was that when you looked at the whole blood group, and this is probably dependent on the protocols that are used for when the decision is made to use whole blood or not, the whole blood group typically tends to be sicker in many of these retrospective, sort of prospective evaluations. In this particular trial, these patients who were getting whole blood typically had lower systolic pressures, they had worse GCS on arrival, and a higher lactate on arrival, again suggesting that they may be a little bit sicker and more likely to do poorly. But when they took their data and actually analyzed it, what they found is using both weighted and unweighted analysis, the major predictor for 30-day survival was whether or not the patient had gotten whole blood. And when they looked at it in an unweighted analysis, and again, factoring in age, gender, which may pertain to the mechanism of injury, the injury severity score itself, the scene systolic blood pressure, and the lactate on arrival, that the most predictive factor was whether or not the patient had gotten whole blood early on in their resuscitation. When they took out some of these components and looked at it a little bit more from a weighted approach, again, not quite as prominent, but still whole blood was evidenced there as to be a major predictor of survival. Now, what's kind of interesting when you actually look at this raw data set is that, again, the survival to discharge was very similar between the groups. It was 75 versus 76%. So how did they say that whole blood was still better at contributing to survival, or at least being associated with survival? It turns out, again, since you had a sicker group of patients, the fact that the survival was the same suggested that there was still benefit to whole blood, because without that, the analysis would suggest that they should have had a higher mortality rate. And this is what I actually want to take away from this paper for the most part, because I think this is reflected in some of the other work that's out there right now. And that is, when you look at the use of whole blood, what we really are trying to look for, and I think now, is identify that sort of sweet spot here. If you look at the administration of whole blood in blue there, comparing it to those who got component-based resuscitation there in red, looking at the probability of survival, and again, some of this is sort of curve modeling and estimates based on the data they had, they found that there was a specific range of severity where if you were mildly injured, injury severity score of around 5 or less, let's say, versus those who had injury severity score up to about 40 or greater than, I should say, greater than 40, that being super injured and having a very low probability of survival, no clear benefit to using whole blood in that population. If you had minor injuries, there was no clear benefit, but there's probably a group that there is clear benefit in terms of improving survival based on the suggestion from their data. And the way they summarize this was that, again, if you look at the improved survival that occurred with this particular group, the odds ratio of about 4-fold improvement using whole blood over component therapy, again, based on a single trial with their own specific indications for when whole blood was used, whole blood looked better. They also saw that, again, once whole blood had been administered early on, there was a decreased need for overall transfusion amounts, about a 60% less component product required, and that the effect on survival was still present there when you looked at the subgroups in this particular study here as well. Again, the subgroups that they were most interested in, didn't matter whether you got it pre-hospital or as soon as you got to the hospital. It didn't matter, again, whether you had, and they used bigger groups here rather than those ones I identified earlier, but an injury severity score of less than 15 versus greater than 15, you still had benefit. And surprisingly, the TBI versus no TBI, whole blood was still reflected as having some benefit on outcome or being associated with better outcomes, which is unusual because TBI by itself is typically a predictor of increased mortality and or worse outcomes associated for these patients. So again, this is about a year-old paper now, but again, from a single center where there's fairly aggressive use of whole blood, very much suggesting that there is some benefit to whole blood. More recently, we've had several other trials that have come out. This particular one was a prospective observational multi-center trial, pooled data from 7 level 1 trauma centers, looking at the use of whole blood versus blood component therapy. Now, one of the things you're going to see in each of these slides when I talk about these papers is what the primary outcome was and the secondary outcomes. And this is probably the biggest difficulty we're going to have in terms of comparing data between these studies, is that every last one of them uses a different primary outcome. A 4-hour mortality is relatively a very short outcome and not one that most of us would be looking for. We would like to see something more like the 24 or 28-day mortality rate, patient-centered outcomes, that look at functional outcomes, for the long term. But nonetheless, this particular one looked at a 4-hour mortality, secondary outcomes looking at 24-hour, 28 days, whether or not hemostasis was achieved in a particular patient, whether the patient was deemed to have had his death caused by bleeding, and whether or not there was an incidence of unexpected survivors, because they were really dealing with pre-hospital probabilities of dying and whether or not the administration of whole blood improved the likelihood of survival. And again, I think this is sort of the takeaway from this particular trial. Again, they enrolled, I think, about 1,000 patients in this particular trial. Overall, what they did not see was any independent predictor of survival for the entire population. If you gave whole blood, it really did not show that everyone was likely to benefit from this. What they did, though, is that they looked at whether or not the patients had a pre-hospital probability of dying and whether or not there was a difference between the use of components versus whole blood. And as you can see here, the pre-hospital probability of dying, from 0 to about 50%, that little dashed line there represents sort of the, proportion dying matching up to that. And it looks at, as soon as you start getting a moderate degree of injury, increased likelihood of not surviving, that whole blood was associated with a increased likelihood of survival. So this may actually mirror a little bit the data from that last study that we're talking about, that there's a sweet spot. Giving it to patients who have a low probability of death, low level of injury, really sort of, again, is less likely to be beneficial. The ones who are likely to benefit the most are those who have, again, higher injury severity scores and other associated factors that may contribute to a higher likelihood of dying in that early period. So again, I think it just sort of kind of supports that concept that whole blood, if it's going to be beneficial, needs to be given early and perhaps in our more severely injured patients rather than just everyone as a whole. Not going to stop there because, again, we have a few other trials that actually have also looked at whole blood. This is one where the use of cold stored whole blood was looked at in a prospective observational multi-center study. Here, kind of pulling the data from 14 U.S. centers. Again, whole blood versus blood component therapy. Primary outcome was in-hospital mortality. Secondary outcomes tended to look more at DVT or PE, bleeding complications, things that may be associated with thromboembolic events, and then acute kidney injury as a marker of end organ dysfunction. And again, with this particular trial, they ended up with 1,600 patients from the 14 centers. Again, about 1,100 of these actually ended up having whole blood, and about 400 ended up having falling into that component therapy group. And as you can see here, the mortality reduction was about 48% in those patients who got whole blood. So it tended to do actually better in this particular trial. Now, one of the things that I'd love to talk about at the very end here, and we get back to discussing whole blood and how we use it, is the fact that when you actually look at the median number of units used in this particular study, and this kind of actually compares, similarly to other studies out there, was 2. The interquartile range was 1 to 3. So the question is, if we have whole blood available, how much do you actually have access to? And does the amount that you have access to also influence your outcomes? Something that people have not been able to tease out yet, but certainly as we progress on and do some more studies, which certainly is something to look at, would be the protocols for when and how whole blood is deployed in the management of these patients. And this particular trial, I think if you look at the benefit, and I always like to kind of look at the shape of the curves themselves, it looks like, again, the mortality difference is about the same going across here, but really most of that benefit is clearly within the first couple of days. And when you even look at the first 24 hours, you see a separation in outcomes, which again may then be extended into that sort of long-term, 60-day outcome, where there clearly is overall a retained benefit out to that time period. Finally, again, we know that we're using this whole blood not only in the hospital as well, but again, we're using it as a component of our massive transfusion protocols. This particular trial looked in a retrospective fashion at the American College of Surgeons, Trauma Quality Improvement Project data set. What they were interested in looking at was whether or not the inclusion of whole blood as part of a massive transfusion protocol, so not the use of whole blood exclusively as part of a resuscitation, did it influence outcomes as compared to simply giving a massive transfusion protocol alone within that first 24 hours of admission. And so looking at 24-hour and 30-day survival, defining their inclusion of patients as those who had a systolic pressure less than 90, a shock index of greater than 1, who had already received 4 units of red cells within the first hour. So folks who are very much likely already in the middle of a massive transfusion protocol, did the early administration of whole blood affect outcomes? Now, one of the problems with this trial, of course, is that, again, they didn't have, really small numbers. Actually, I say it's a benefit of this one. They had included almost 3,000 patients. Now, the majority of these had simply a straightforward massive transfusion protocol. Only about 25% of them, a little over 400, actually ended up having whole blood as part of their initial and early resuscitation. And just like in that last trial, the number of units, the median number of units was 1. So again, this may be somebody who in a pre-hospital environment was administered whole blood, but upon arrival to the actual emergency department, ended up having an ongoing resuscitation with component-based therapy in a massive transfusion protocol. And again, when you look at the actual outcomes, though, whether they got whole blood or not, again, there was a 37% reduction in mortality at that initial 24-hour period, which at the 30-day period was about 47%. So again, this kind of raises that question that even if you're only using a couple units of whole blood, not the sole component in your massive transfusion protocol, is there some benefit simply to including even a couple of units early on? And again, I'll be interested in hearing about everybody's experiences when we sort of get a chance to come back and discuss some of these topics. And then finally, pre-hospital whole blood, we think makes a difference. You know, in our institution, we are now seeing an increasing number of patients who are getting whole blood in the field. This particular retrospective review, which used 2 level 1 trauma centers, both of them down in San Antonio, Texas. They looked at all patients who had undergone transfusion on arrival to the trauma bay with and without pre-hospital administration of whole blood. Now, again, this is a fairly smaller study, so not as many patients. I think they had 1,400 patients, of only 171 got whole blood. And what they found, or what they were looking for, was whether or not the stroke index on arrival was better in those who got whole blood, and whether or not those patients progressed on to need a massive transfusion protocol. And what they found when they got to their multivariate analysis, looking at the injuries patterns, again, specifically the injury severity score, how much pre-hospital crystalloid was administered, whether it was penetrating versus blunt trauma or age, they found even in their multivariate analysis that, again, the use of whole blood in the pre-hospital setting, similar to the injury severity score, were both associated with improvements in overall outcomes. But again, there was more penetrating trauma, a higher shock index, lower age, lower systolic blood pressure, and those patients who got whole blood. So it was probably, again, protocol driven as to who fell into that category. And it's, again, not clear necessarily whether or not it's the protocol that improves outcomes or the use of whole blood as a component of that protocol. But again, it's limited, again, by the numbers of patients as to whether or not there's any impact on mortality. But again, suggesting that whole blood in the pre-hospital setting may be beneficial. And I want to just take a second just to kind of, let you know what at least what I've seen in the data sets out there with regards to how much whole blood is being used in the setting. There was a survey just a couple of years ago. Now I think it's probably about 1.5 years, 2 years out, where they checked with all of the level 1 trauma centers in the U.S. and asked folks, do you have access to uncross-matched plasma, the group-based plasma, and how many of y'all have access to this low titer O whole blood? And as you can see here, there's been an increasing number of folks up to about 2020. I suspect that line has continued to climb to the right there, similar to what you see with the plasma back about 10 years ago. And they had some specific questions. For the groups that were out there, at least 55% of the centers, if they had not already started using whole blood, were planning on implementing it in the near future. And one of those questions that I raised earlier was how and much blood you actually have access to as part of your resuscitation. Interestingly enough, whether there was no limit or if a limit of greater than 10 units but not unlimited, sort of falls in that category. The majority of us actually do deal with limits. I know in our own institution, our initial resuscitation is with 4 units. We can get additional 4 units to 6 units, depending on what's available. So we're probably limited to somewhere between 8 to 10 units of whole blood. I saw Justin Richards on the talk here. He can certainly fill us in more on the practices here at Shock Trauma. But again, it's not unlimited access, as we know. When you actually look at obstacles to instituting a whole blood program, clearly it's cost. There's some concern from our blood bankers about a fear of wastage, because again, if you have a fairly moderately expensive, asset on the shelf and you may not use it, they consider this to have a 21-day shelf life. They certainly don't want the cost of having it available if it's not going to be used. Setting the acceptable titer levels, again, is something that has to be negotiated between the folks doing the resuscitation, the hospital, and the blood banks. Consensus on usage. So again, patients who need transfusions aren't just going to get whole blood just for the sake of getting pack cells. So you have to have an agreement on when and how these should be used. So there should be a protocol in place. Our institution has one that sits up in our trauma resuscitation unit that Justin Richards worked on a number of years ago to sort of drive when we should be immediately reaching for whole blood versus perhaps considering component therapy in our less unstable patients. And then finally, donor recruitment, availability of products, and whether or not logistically you're getting your blood directly from a blood processing center versus a blood bank may also influence, your ability to initiate or run a whole blood program. I think, what we're really looking for now, because all those studies I just gave you, 5 of them, Every last one of them is retrospective or at least prospective observational. There are no controls in there. There is a trial that is underway already, the TROOP trial, the trauma resuscitation with group O whole blood or products. It's underway. For those of y'all at WashU, I know that you are one of the potential sites, as we are at Maryland, although at least last time I looked on the site, neither of our sites were actually actively recruiting, but they are already recruiting in Seattle, Cincinnati, and Birmingham, some of the other centers involved in this trial. And again, this may, if it gets off the ground and gets running well, actually give us some data on whether or not, from a randomized perspective, does giving whole blood make a difference in outcomes as compared to component-based resuscitation. I'm going to move on to adjuncts now. And this actually is a little bit of something that, again, I'm just going to give credit to Justin Richards for this because he's talked a lot with us about, hemorrhagic shock and vasopressors. If you actually look out there, the patient is actively bleeding out on you, where you're trying to get control of hemorrhage. You clearly are volume down acutely. Most of these patients have sort of a sympathetic sort of drive. So again, they're vasoconstricted, they're tachycardic, and giving pressors in that setting is not going to fix the problem. It's volume, it's control of the bleeding that needs to be done. But as patients have, sort of this persistent state of shock, so sort of a prolonged, let's say, non-immediate, exsanguinating event where you're just trying to keep up with ongoing losses while you're operating on the patient, they sort of kind of at some point transition frequently into sort of, this sympatho-inhibitory phase of shock. And again, where vasodilation can occur, and it's those patients where potentially vasopressors may be beneficial. Similar to what you see with patients who end up in the ICU, who have an inflammatory response both to shock and tissue injury, again, after severe blood loss, where again, the use of pressors may be necessary to sustain systemic perfusion, while you have your ongoing resuscitation and or resolution of that inflammatory phase. We've had this question out for years, right? And if you go back to the earlier data about whether early vasopressor administration increases mortality and complications, the early data would suggest it would. But again, a lot of that was retrospective data where vasopressors were being administered as sort of a last-ditch effort, and they were associated with increased mortality. Again, just from a retrospective, very biased approach to how it was done. More recently, we saw the trial with arginine vasopressin, again, not ones I'm talking about, but from 2019, where again, randomized trial, 100 patients, after they'd already gotten 6 units of products within 12 hours of injury, either got randomized to placebo or started on vasopressin, a bolus plus an infusion that target a MAP of 65 up to 48 hours after injury. And the primary outcome was looking to see if they could decrease blood product requirements and did it affect other significant outcomes. And it turns out you could actually decrease the requirement for blood by administering some vasopressors, and it was not associated with, at least in the small trial, worse outcomes in terms of mortality or end-organ dysfunction. So this is one of those trials that I think is sort of provocative, not necessarily definitively answering the question, but this was a trial where, again, it was more of, again, a retrospective multi-center review of several trauma registries, which included us here at Shock Trauma. And I think Justin Richards was involved with this trial. And what they did is they wanted to look at blunt trauma patients in hemorrhagic shock. And in some of the currently published guidelines for the European management of the hemorrhaging patient, there's recommendations for the use of pressors and those who are otherwise not responding to volume, who may look like they're getting to be volume replete, but still have that sort of sort of that sympatho-inhibitory phase perhaps developing. And again, whether it was started pre-hospital or in the resuscitation room, they've looked at those patients who had received norepinephrine at some point versus those that didn't. And what they found is that those who actually were getting norepinephrine, at least based on roughly these European guidelines, there was no difference in 24-hour or in-hospital mortality. So a bit of a contradiction to what we've seen in the past with respect to early norepinephrine administration. Now, again, I think this is sort of a nuanced approach that needs to be applied to this. When we've talked about resuscitation of patients with massive hemorrhage, ongoing hemorrhage, there's been this question of permissive hypotension in selected patient populations. How aggressively do we have to restore the blood pressure? Should pressors be used to hit a specific target when otherwise they could be avoided? Certainly has been a question. I mean, clearly there is some potential benefit to using pressors for selected patients. It may decrease your venous system compliance. It kind of augments that mean systemic filling pressure. so that the stress blood volume is actually increased, and which results in increased cardiac output, improved perfusion. We also see individuals, and it's been recommended to use boluses of either vasopressin or norepinephrine for induction or phenylephrine, something to actually kind of blunt some of the hemodynamic effects that occur with the administration of our anesthetics. And similarly, when we get to the operating room, even in those patients who've been moderately well volume resuscitated, even the administration of inhalational or IV anesthetic agents, including narcotics, have the potential to sort of blunt some of that vasoconstriction that may be occurring. So you get a little bit of mild vasoplegia, and perhaps the use of suppressors in that setting, just like we're talking about now with intraoperative hypotension. I don't know about you, but we're seeing an increased usage of pressors in the OR to hit specific intraoperative targets for blood pressure. Certainly, again, very similar to what you might be thinking about with these patients. Now, the caveat to all this is really about filling the tank. And when it comes to that nuanced approach to usage, again, it's likely to benefit certain patient populations better. The ones that clearly need higher blood pressure, again, traumatic brain injury, spinal cord injury, certainly may have better outcomes if they maintain higher pressures early on, been suggested for both populations. And that specific guidelines, just to let you know what they look like in the European guidelines on the management of major bleeding and coagulopathy following trauma, the 6th edition, which was just published this year. If you haven't seen it, I recommend kind of going through it. It does have a few changes from the previous edition from several years ago. But when it comes to pressor, this is the only place you'll see recommendations that specifically state if a restricted volume replacement strategy does not achieve the target blood pressure, they recommend the administration of noradrenaline in addition to fluids to maintain target arterial pressure. Again, no specific guidelines on what to use, about what should be your targets. But again, if you're having trouble maintaining a blood pressure, you think the patient is adequately volume resuscitated, and this goes back to whatever markers you have clinically available to you to show you whether or not the patient is likely to be volume responsive. And again, if they're not volume responsive, they may have entered this sort of vasoinhibitory phase, then absolutely the use of pressors may be something that we need to think more about at selected points during our trauma resuscitation. Moving on to another adjunct that we've talked about for several years now, we know that sort of the open thoracotomy approach may be absolutely indicated with cross-clamping of the aorta, particularly for patients with penetrating thoracic trauma. But for a lot of our other patients who are showing up in sort of either trauma arrest or who may be profoundly hypotensive with suggested mechanisms of injury that would not be beneficial to opening the chest, we're seeing an increased use of resuscitative endovascular balloon occlusion of the aorta, or the REBOA. It's also kind of nice because you get that sort of early ability to monitor blood pressure without having to get a dedicated arterial line. Something that, again, for our patients in arrest, we frequently place sort of up into that zone 1 region above the renal arteries, and again, get occlusion here of the aorta to improve, central perfusion, coronaries, the brain, etc. Now, what's new in this area? I think this is the one that, again, to a large degree, we're kind of stymied in interpretation of what the REBOA really means. I've seen some conflicting data. Data simply looking at the, the trauma quality data sets, the TQIP, suggests that actually the REBOA may be associated with worse outcomes. Whereas when you actually look at the REBOA registries, the ones that are maintained by the American College of Surgeons, they've been suggesting that there's some benefit there. But obviously, there is some bias in both those trials in terms of how the REBOA is employed, since it's not been done in a randomized fashion. This particular trial was, again, a sort of a comparative effectiveness study, looking at the use of REBOA Zone 1 versus resuscitative thoracotomy. They used that sort of American College of Surgeons registry, which now has thousands of entries into it. And then primary outcome is in-hospital survival, looking at some secondary outcomes of vent-free data, length of stay, and sort of neurologic outcomes associated with the resuscitation. And what they found, and again, this is in a very non-biased sort of way, because what they tried to do was, as opposed to just looking at absolute outcomes, they tried to do some propensity matching. So for patients who got the REBOA versus those who got a resuscitative thoracotomy, they tried to balance out all the other risk factors, systolic pressure on admission, age, comorbidities, mechanism of injury, and they even included the institution in there, because I think there are some institutional biases in terms of when these things are deployed and the outcomes associated with them as well. And when they actually looked at this trial, again, when you look at it here, they really got it down to about 112 patients. that they looked at here. And there was a suggestion, at least from this signal, that the Reboa still was associated with an improved likelihood of survival as compared to a resuscitative thoracotomy. And these are patients in arrest. So again, I think what the real bottom line from this is that at least the surgeons believe that, again, based on these findings, they might be able to actually now use that as justification, the equipoise that's present here between the two approaches. Again, that they might be able to do a randomized controlled trial to establish the safety and effectiveness of Reboazone 1, for a aortic occlusion in our trauma resuscitation patients. So I think this is just sort of a highlight of where we're likely to be going with this. But at the same time, I think one of the things that gets underemphasized in many of these studies, but if you look at the bottom line, you'll see this, is that the Reboa is often associated with increased vascular complications, including amputations, particularly for centers when they're first adopting and employing this. We saw it in our institution. And I got to tell you, I think we're actually using fewer Reboas now than we, applications than we did 3 or 4 years ago when we were first trying to really get our hands on what was good and what was bad about using it. And I think the bottom line is too, when you think about the vascular injuries here, it's probably the only thing I really learned from 11 seasons of The Walking Dead is that it is really life over limb. Sometimes, again, if you get the benefit of the Reboa, the risk of vascular occlusion, thrombosis, distal ischemia, et cetera, is outweighed by the benefit you earn in that particular setting. Moving on, again, I think in terms of adjuncts, I think, PCCs have been a component of some of the resuscitation protocols for treating coagulopathy, particularly in the European approach, which is much more driven by viscoelastic testing and algorithmic application of the use of specific agents in that particular setting. The ProCoax trial, which is a randomized trial, which was actually looking at the use of 4-factor prothrombin complex concentrates, PCCs, in a randomized placebo-controlled trial, was employed in France at 12 different level 1 trauma centers, so a multi-center, blinded, randomized controlled trial, looking at the use of 25 international units per kilo of 4-factor PCCs versus saline. And again, just have to remember, 25 units is sort of on the low, I won't say the lowest end, but it's sort of the medium dose. 50 units is considered a high dose and has been recommended in some settings for sort of managing severe coagulopathies. Primary outcomes, again, 24-hour all blood product usage. So again, did administering PCCs decrease blood product usage? And was it associated with arterial or venous thromboembolic events, sort of a secondary outcome? Now, again, you'll notice here they did not include any mortality-based data and did not observe any differences in mortality, although, again, it was not one of the primary outcomes. When they actually looked at this, and again, this was including about 300 and so a little over 300 patients, when they actually looked at this, there was absolutely no difference, at least in their protocol-based approach, in the use of blood products, whether it was total or any specific individual products across that early resuscitation phase. And this is really out to 24 hours that they looked at. What they did note that there was a higher risk of thromboembolic events in the PCC groups. Now, does this preclude, from the future of anybody doing a more expanded trial, randomized trial, trying to incorporate PCCs as a component, or at least an empirically driven component for resuscitation? Probably not. Now, will it fall off of the actual algorithmic-based approach? Again, probably not, because again, if you do need specific components that are present in the PCCs and directed by some sort of viscoelastic or other type of monitoring system that kind of targets those elements, then certainly that doesn't really disprove the utility in that approach, but just empirically did not suggest that it would at least decrease the number of blood products required as a suggested marker of improving the coagulopathic state of the patient. And of course, for those of us who track things like money or have to deal with it with our institutions, the cost for about 25 international units per kilo is about $5,000 to $7,000. Kind of a big ask if you're talking about from an empiric standpoint, and you don't have a real good, clear indication that giving it empirically to certain patient populations is likely to be beneficial. One of the other areas that I'm going to touch on, again, looking at adjuncts, is sort of the thing that we're all dealing with now. I don't know about WashU, but at trauma, a few years ago, we ended up getting a sort of hybrid operating room and trauma vascular surgeons who were very willing to take patients to the OR for sort of those IR-based procedures that in the past we would have intubated the patients, sedated them, and may or may not have gone with them to the IR suite while they got angio and or angioembolization of potential bleeding sites or evaluation for bleeding. And again, those liver bleeds are pretty problematic, and it wasn't uncommon a few years ago for us to be asked to take many of these patients to the OR and getting sort of that angioembolization done, treat that little blush they saw in there prior to actually getting an operative approach or simply for non-operative management. And this is one of those things the surgeons mentioned to me that I think is going to change a little bit in our practice. Again, looking at a multi-center study of perioperative hepatic angioembolization as an adjunct for management of major operative hepatic trauma. Again, a retrospective multi-center trial looking at 13 level 1 and 2 trauma centers across a 9-year time period. Individuals who came in with a liver trauma, grade 3 or higher, were requiring operative management, and whether or not angioembolization was incorporated as an initial management approach prior to actually going for surgery. Turns out when they looked at local hepatic necrosis-related complications, need for additional procedures, and then secondary outcomes of hospital mortality, length of stay, ventilator days, turns out that angioembolization was actually associated with more complications, significantly more. And they had 400 patients in this group. And again, they had increased myeloma formation, increased intra-abdominal abscesses. Our folks here talked about more necrotic liver and having to go back in and do repeated resections. So again, did not necessarily find that angioembolization as a sort of preoperative intervention improved our outcomes in those patients with liver bleeding. So that's some of those things I think we'll see ourselves backing off of a little bit compared to what we did in the past. And I think finally here, I kind of want to get down next to last one, this question of artificial intelligence. Yeah, has anybody picked up a journal lately, even a magazine, and haven't seen the words artificial intelligence in at least one title and one article in that particular journal? Clearly, there's a lot of things out there that we've been incorporating for years, whether it's artificial intelligence, machine learning, or some of these neural nets or deep learning techniques to try and improve patient outcomes by incorporating or evaluating these large data sets. And I think, again, what I'm looking at here is not so much artificial intelligence, so they classified it as that, but really it's that deep learning neural nets, where again, image classification, being able to show images to a computerized system, being able to analyze this, certainly may affect how we use some of our imaging modalities in the future. From an AI perspective, again, looking at the FAST exam. I don't know about y'all, but we get a lot of transfers from outside hospitals where an exam is done, an interpretation made, it shows up on our doorstep, we run it by our radiologist, and it's not there. Again, that was the a sensible reason for why a patient was transferred to our institution. So again, over triage, which ties up our system with patients who may not have been necessarily need to be treated at a level 1 trauma center, but could have been managed at the site that they were at. Similarly, when you look at the FAST exam, it's pretty straightforward. You think most people should be able to clearly identify the presence of fluid, whether it's positive or not, be able to identify the organs that they're looking at. And again, in this particular trial, what they did is they used data from prior, FAST exams, both right and upper left quadrant. They classified them as having fluid. They classified as whether or not the views that were obtained were adequate for the liver, kidney, or spleen. They ran it through their deep learning sort of neural network to define what is positive, what is negative. And then again, once they reran the system, training data set, validation data set, and then a bunch of random ones that were done and added into the system, turns out what they had in terms of being able to identify the presence of fluid here, they could do it with 98% accuracy, 90% sensitivity, and 100% specificity. If it was there, they saw it. And again, the overcall was not all that much. When they looked at adequate exams, being able to say whether or not the person doing the imaging had obtained appropriate views of the liver and kidney interface or the spleen-kidney interface, 89% accurate, 83% sensitivity, and 94% specificity. So again, if you're thinking about remote sites where people may not have the skill sets to be able to accurately do a FAST exam or may not have the experience to consistently interpret those images correctly, a system like this would be very useful. I remember talking to Ron Salmon, who I actually see on the conversation today, one of our regional guys at Shock Trauma, The regional guys, regional anesthesia guys are already starting to see this incorporated into devices that are commercially available. You can actually put an image up like this that actually shows the muscles, shows the vessel, shows the nerve, and actually then can kind of guide you through actually doing a procedure and hopefully improving the accuracy and effectiveness of this. So when you think about it in terms of what we're doing here, with AI, remote locations, the ability to do this in the field, is it something our pre-hospital personnel are going to be able to do, and perhaps better triage patients to go onto a trauma center, maybe bypass that local ER if there clearly is something that suggests that the patient needs a higher level of care. Again, it's that over and under triage scenarios where something like this will be extremely useful in the future. So again, I think, this is a general topic for discussion, the value of AI and how we can incorporate it into our practice. Additionally, outside of imaging, we're seeing it started being incorporated into many of our decision trees, right? If you have a resuscitation in process and a background process running that's actually assessing all of the data coming in, hemodynamic data, procedural data that's being entered in, if you could do it real time, might better guide your resuscitation as well and make suggestions or offerings that, again, might improve your patient outcomes. And I think I'm going to finish up with one last article. And again, this is one that I've been kind of waiting on for several years, knowing that it's out there. We all know coagulopathy is the killer, right? And again, one of the things that we've talked about, and I think everybody already has pretty much formulated their opinions on its utility, is the use of TXA. Ever since the CRASH 2 trial came out, there's been this suggestion that TXA may save lives. One of the biggest early questions was whether or not in a high resource environment, Europe, the United States, Australia, New Zealand, whether or not TXA is truly beneficial as compared to a lower resource environment where they may not have as much access to blood products, longer transport times, less effective surgical interventions, et cetera. This is the PATCH trial, just got published again this year in the New England Journal of Medicine, specifically looking at pre-hospital TXA for severe trauma. In this particular trial, they had 15 EDs in Australia, New Zealand, and Germany. Pre-hospital administration of TXA was done with 1 gram plus an infusion versus a straight up placebo, and again, blinded. So no clear knowledge of what was being administered. The primary outcome here was one that I'm hoping to see more in the future, at least in terms of our outcome studies, and that is survival with a functional outcome. Surviving by itself often is not the best marker of the benefit of a particular solution. In traumatic brain injury for years, we've known that things like decompressive craniectomies actually improve survival, but they also lead to a lot of patients with very poor neurologic outcomes who survive. Again, perhaps not the optimal solution that many individuals would consider appropriate if you think of patient-centered outcomes, what a patient would want in that particular environment. They also looked at 28-day mortality. And again, when they looked at, 1,300 patients, mostly with blunt trauma, at risk for coagulopathy, including patients with traumatic brain injury, kind of feeding into the CRASH 3 trial data that we saw come out. Absolutely no difference in outcomes. If you actually look at what they consider to be good outcomes, which again, patients with a low, moderate disability and survival, again, absolutely no difference whether they got TXA or not. Again, also no harm associated with it either. So again, did not see any increased incidence of thromboembolic events or anything that would be considered an adverse outcome associated with its use. In Maryland, our pre-hospital folks are using TXA. Again, whether or not it truly adds benefit, I think is still in my mind unclear. I know Justin and I kind of disagree on this a little bit sometimes, but again, not necessarily associated with harm either. So I don't see a problem with doing it if it's something that's incorporated into your protocols already. Other things that are out there that I hope to talk about, next year. One is the Cryostat 2 trial. I think this is again a multi-center, I heard multinational, but mostly based out of the UK trial, specifically looking at pre-hospital administration of cryoprecipitate. Many of y'all remember sort of the pre-hospital use of FFP in this country, which again showed some benefits to administration of FFP. So why not cryoprecipitate, which again incorporates fibrinogen and some other factors, again with major trauma. It's supposedly, if you look on the website, still in the analysis phase, but just this afternoon, I took a look to see where we were at on this trial. And it turns out that Karen Brohe one of the big guys in coagulopathy has actually made a statement now saying that the early empiric administration of high-dose cryoprecipitate to this patient population, did not improve 28-day mortality, and there was possible evidence of harm given very early or in penetrating trauma patients. So again, I'd love to see the final report out on this particular trial. Not there yet, but something that I will be looking forward to seeing. But the early suggestion is that, again, no clear benefit. And this kind of reflects some of the data we already had from several other trials, looking specifically at the administration of fibrinogen concentrates in Europe, that again showed no clear benefit to the administration of fibrinogen supplementation, either in the pre-hospital or early admission phase for many of our bleeding trauma patients. So again, that's kind of where we're at on that particular topic. So I said I'd finish, in a little bit less than an hour and give us some time to ask some questions. I see a couple comments popped up in the chat while I was talking. I'll pop those up and we'll kind of open it up to everyone. I'm going to, again, I saw that, is there a Raj Nathwani who said it seems a bit too good to be true. I'm not sure which one that was referring there, but Raj, if you want to add to that, I'd be happy to.
Tom, that was my response to the whole blood question. 1 to 2 units of whole blood in a retrospective study giving you 48% mortality benefit, which carries over beyond the 30 days. I've got to say, I just cannot believe it, but I wish it is true. Yes, we're one of the sites that have just started enrolling into the troop study, so hopefully that will give us a better look at this picture.
Yeah. Where are you at?
I'm Harborview, Seattle.
Oh, yep. Yeah, you guys are one of the first ones to get on there. I think ours is still in process. Yeah, and I see Justin never disagrees with me, but that's not true. So the whole blood question, for those of y'all who are using whole blood, what is your upper limit for how many units you can use in a resuscitation, or do you have an upper limit?
So, Jason, are we up to 12? I'll see if Jason Gillihan's still on. I know we normally give at least one box.
I think we will be whenever we.
Yeah.
Is that part of the troop thing?
That was been part of our plan from the beginning.
Yeah, we're moving towards 12, but right now.
Jason's going in and out.
But the troop.
Yeah. I know we were trying to get to 12, and that did not include, I think, 2 that were involved or that could be given in the ED as well. So I think the goal was 12 to 14 as our upper limit.
Yeah, and again, that's like I said, when you look at these trials, while they're showing benefit, they're also showing they're not using nearly as much as what many of us are now having access to. So I think it's kind of a rolling target now to look down the line to see if you give 2, 4, 6 units.
Yeah.
And don't get out of the whole blood phase. You start and finish in whole blood. Whether or not those outcomes are different than those patients who start in component, which I'm hoping the troop trial will help us with that. And Justin, are we 8 or 10 now?
We're 10. Technically, it could be 12, but I think to your comment, logistically, most of our people, when we look at our data, we're probably around 2 to 4. Logistically, trying to make sure that they stay in whole blood and not get component therapy is the challenge. But we could go up to 12.
Yeah, I think some of this is just putting it all together, and it's not just the blood part. It's that early intervention. It's maybe it is that IR up front, plus or minus Roboa. I know we're still waiting to have a Roboa talk, because we are definitely not a Roboa institution. So I'm still looking for someone. If there's someone at Shock Trauma, I know Justin, you tried to put me in touch with someone. I never really got a response, but if there's anyone there at Harborview that pushes for it, we would love to have someone, a proponent. Because
I've got somebody. I'll get them in touch with you.
Okay.
Yeah. Harborview is not a very pro-Roboa institution, and obviously the UK. I kind of was involved with the UK Roboa trial when it kicked off in the UK, and the results came out this year and weren't very positive, to be honest. And obviously, getting patients into that got drawn out over the COVID period, so that really hampered their recruitment, but seemed to imply longer time to intervention. Everything was slowed up. So unless you're a place that does a lot of Reboa, just putting in one or two every now and again really definitely is not beneficial as far as I can see.
Yeah, and I think that's how most of us felt here is we had a couple gurus that would love to put them in, and they would put them in all the time, and the rest of the group really wouldn't. And so we kind of got a mixed experience bag there. I think the topics across the board are so relevant. I mean, these are literally the things we seem to talk about on a daily basis. So I'm glad to see it matches the contemporary literature.
Yeah, the one paper I didn't put in there that I really wanted to, but was a little bit concerned for time, was actually the only anesthesia related one. Evan Pizzoliva down in Houston, went through the proper data set and looked at the impact of the choice of anesthesia and the amount of narcotics patient we're getting, and looked at that associated with outcomes. One of the things that I was taught when I first came to shock trauma 20 years ago now was that, just hitting that target of 3 numbers over 2, when you're resuscitation in the OR is the macro. What we're really looking for is, micro resuscitation, micro perfusion. And frequently if you're vasoconstricted, you're not getting adequate perfusion. The best way to test that is just deepen your anesthetic. If you give somebody 50 mics of fentanyl and they bottom out their pressure, they need more volume or pressors now, would be the question, for Justin, how to make that distinguishing that factor between the patient who is simply still a little volume under resuscitated, or again, has hit that sort of sympathoinhibitory phase where they actually need to go on pressors. And that's hard. For me, I think that's still a hard decision to make. And usually I do both. So that's how I get around it.
Justin,
well, Tom, let me comment if I may into Justin. So Justin, your initial comments about trying to make this like a multi-institution kind of endeavor, I think is a great idea. I mean, we could take over the world doing this with the number of places that can be involved. Tom, I appreciate all the yeah, well, I mean, this is the way to do it. I mean, we really, really can. And that's a question I've asked of Jason in the past of where the TAS is going. I think this is like a perfect example of it. Tom, I'll say appreciate the shout outs. I promise I didn't pay you anything to say all that. But I think you make a great point of where we are now, and to Knittle's comment about these are topics we all talk about. And I think we are well beyond the at least period of resuscitating every person the same way. And there's got to be a nuanced approach, and not every bleeding person is going to need vasopressors. Not every bleeding person is going to need cryoprecipitate or PCCs, but trying to figure out who those people are. And that was the topic really of Thor this past year, was is it the right intervention in the right person at the right time? I'm curious to see if artificial intelligence can actually help us with that at all. I don't want to drink that Kool-Aid, but admittedly, we're looking at it.
No, I think that's an intriguing topic about how we can, maybe stretch our reach a little bit farther. And, just like we're doing in the ICUs, I think being able to do procedures or help people through procedures and reach out with our expertise to different places, I think there's a lot of promise there. It's intriguing. It's coming one way or another. It's coming. How it's going.
And one of the comments that I want to pass on, because we've had this comment in other meetings, from like Jean-Francois Pité down in Alabama, is that most of the resuscitation research doesn't include anesthesiologists. But I've never seen a surgeon hang a unit of blood ever in my life, or make that decision of when to go on pressors. That's us. We're kind of on the periphery. Like I said, they're skimming our data, to come up and make their conclusions. So, and again, but we're the ones who see the hands-on, I do this is what happens, kind of approach. And the cumulative knowledge we get, from everybody here, who've been working for a number of years with these patients, I think is pretty essential to drive some of the research questions, and practicality. One of the first questions I had for the proper trial was, and no one's actually done this analysis yet, by the way, is that I know how we practice. How many of y'all don't empty the cooler.
Don't?
Yeah. When you get your blood cooler, how many of y'all don't empty it typically?
Oh, I make a point.
Almost everybody, again,
I
a
only
lot of
give
people will just,
coolers,
if
I
you
don't
have an
give-
extra unit, just go ahead and hang it. Particularly if you're going up to the ICU or something post-op.
Yeah.
So when you actually look at the way they did their divisions, you're almost guaranteed to get certain ratios. I mean, again, it was designed to do certain ratios, but your volume is less with one cooler versus another cooler, for the specific arms. So, it'd be interesting to see how many people use the full cooler versus just part of a cooler. Absolute number of units, broken out by that. It's little practice things that we do that nobody else thinks about.
That comes back to your question of, it's the question with massive transfusion of when do you stop?
Mhm.
That'd be an interesting. I have my thoughts. There's data. Well, I've not proved. We could actually prove that in a way, but that could be another talk, Justin. Of
Hey.
At what point does when are they no longer volume responsive?
I have plenty of openings next year. I'm delighted to have you on. You just tell me, I'll give you a list of dates.
Yeah. Any other questions or thoughts from the rest of the folks who are signed in? I'm always curious about this. The vasopressor one is, one of those things that it's nice to see it in the European guidelines, but I know it's also common practice for many of us at some point to do this. And I talk to a lot of folks who are not in a level 1 trauma center. These are folks in the small rural hospitals who are resuscitating patients and then sending them to you. And how many of those do you see come in on norepinephrine routinely? Or have gotten 7, 8, 9 liters of crystalloid as part of their resuscitation still. And it's not, and again, this is not that they don't want to do blood products, they just don't have them, with the ready access that we do. And if you're transporting a patient, their pressure is going to drop. What are you going to do? You might as well have them on a pressor to start with. And that helps you manage mentrop till you get them to wherever they're going to get, again, access to more care and more resources.
Yeah, I would prefer that over crystalloids.
And that's pretty much my recommendation now is, go on a little bit of low dose pressor, but again, crystalloid is the killer, of the things that we can do in lieu of having access to all the resources.
Any other comments? There are a lot of surgery folks here. I know we have a few anesthesiologists. Well, it's been a pleasure. Thank you again. Looking forward to this next year if you're still willing. And yeah, thank you all for coming. Next month, one of our pharmacists is actually going to be talking about DVT prophylaxis in trauma patients and how we can do a better job. So more about the continuity of care, more about the care after the initial trauma, but something that we all see in the ICU and something that's I think we can definitely improve on. So it should be a good talk. Thank you guys, and like I said, I'll get this up this week to the YouTube channel. Tom, once again, thank you so much for your time. It's been wonderful.
And thank you for the invitation. I enjoyed it. My email address on there at the end. If anybody has any questions or thoughts or like you screwed this up, please pass it on.
Absolutely. All right. Thanks, guys.